All right, so let's talk about cannabis. I don't know what your experiences are with it. This is not a judgment thing. I think cannabis has, like everything, a time and a place. It's very good for insomnia and sleep. It's very good for extremely difficult pain states like rheumatoid arthritis or pain that's refractory from HIV. Those are great populations to use this. However, for everybody else, man, does it make my life so difficult. I can tell that someone uses a cannabis as a pain physician just based on their reactions to basic pain states. So it's a big problem for me. Again, unfortunately, I have no financial disclosures. We're going to review cannabis routes of administration and the impacts on the pharmacokinetics. We're going to summarize some known physiologic effects and what's relevant for the perioperative period, and we're going to define an approach to assessing cannabis use. Another thing that I just want to blanket statement here is that because cannabis is now legal in many, many places, in fact, I have a map here, the light green is the states with legal medical marijuana, and the dark green are states that not only have the legal medical marijuana, but they also have the recreational marijuana. But so now that it is just so widespread and decriminalized, we are now getting a lot more patients, but they're still working on the research. So a lot of things I'm going to say, you just need to take with a grain of salt because it's still being solidified. And based on which organization you talk to, they have different recommendations. So really, it's just, what I'm trying to say is just try to be aware that this can happen, even though I'm not guaranteeing it's going to happen. We need more time. And with the millions of people that now want to use cannabis, I'm sure we will get all of this data very soon. So there are some important terms and definitions. You've got the cannabinoids and then the cannabis-based medications. And cannabinoids are molecules with activity at the cannabinoid receptor, which is the most prevalent receptor in your entire body, way more than your mu receptors for opioids. It is like an ancient receptor. It's in your brain and it's in your periphery. So you've got your phytocannabinoids, which is your THC and your CBD, your endocannabinoids, which is your AEA and your 2-AG, and then your synthetics. As far as the cannabis-based medications, you have your synthetic dronabinol and nabilone, which used to be used a lot for appetite stimulation. And then you have your plant-derived, which I am not going to try to say. And then you have your general products, your flowers, your concentrates, your tinctures, topicals, edibles, creams. I mean, this is being touted as the next witchcraft that fixes everything. And it does, kind of. So 18% of the US adult population reports cannabis use, and annually 22 million Americans over 12 use the products, or including patients that have a lot of complexities like heart disease. And you're going to see in a couple slides from now how that's something we need to start thinking about. I used to just think, oh, marijuana, that's going to alter your state. You're not going to be able to sign my consent form and you're probably going to have pain. But no, it actually affects a lot of different organ systems. So first, you can inhale it or you can ingest it. And I want you to think of this as though if you are breathing it in, it's like an IV bolus of a drug. And if you're ingesting it, it's like a PO bolus. So the inhaled, it peaks at 15 minutes. It can last for a few hours. And the ingested, it lasts a little bit longer, just like with PO, but it takes a little bit longer to kick in. The cognitive effects that one experiences after they take in cannabis can be present for up to 24 hours. So there's a lot of discussion about can you sign a pre-op? Can you consent for yourself or not? It's highly lipid soluble and it can stay in your system for 30 days. So which molecular targets of cannabinoid-mediated pain transmission demonstrate properties of analgesia, motor impairment, tolerance, and reward? So that's what kind of makes people keep going back. It helps with your pain, but it also hits that reward system in your brain. And the CB1 receptors are central, and you got them central and peripheral. The answer is like all of them. So it doesn't matter. You're going to get analgesia, motor impairment, tolerance, and reward no matter what you're taking. So when you're doing a pre-op assessment, you need to, with your focus history, figure out like their level of exposure. Are they naive and they're just trying it now, or are they chronic heavy users? And are they using it recreationally, or do they actually have a medical indication like rheumatoid arthritis or insomnia or whatever? How often are they using it? So your frequency of use each day is directly indicated to whether or not you may have a problem and whether you're going to experience the withdrawal. For chronic users, sometimes they use synthetics. It can be like a very common one is called Spice or K2, and they'll use it also to help with like nausea. So 1.5 grams per day, I just wanted to put this for you because I know I wasn't aware I don't use cannabis, but this is what's considered a lot in grams for inhaled and for the CBD and the THC oils. And expert consensus suggested, like I said, the heavy use is greater than 2 to 3 times per day, no matter what you're using. So day of surgery comes, your patient shows up, they're acutely intoxicated. What do you do? And I don't know if you've been in this situation, but I have been in this situation with many people. And this is where all the different organizations kind of have a different recommendation. So if the patient recently smoked cannabis, some people will tell you to delay elective surgery or to at least wait 2 hours. The ASRA, the American Society of Regional Anesthesia, that's like a acute pain, chronic pain organization, they suggest that there isn't enough evidence in the literature as of right now to make a recommendation. So there's no weaning strategy. So you just have to think about the complexities and take on the risk of doing the case. There are other consensus-based guidelines that say that people need to stop 3 to 10 days before they can come in for their elective surgery. Me, as a pain doctor, I want to know, because I struggle so much overcoming the marijuana effects with pain medicines, how long should you stop before my pain medication will actually have a chance of starting again? It's like for typical, like a naive person who doesn't take narcotics, you would typically order like 5 to 7.5 milligrams of oxycodone every 4 hours. With my marijuana users, I have to start at 10 milligrams, 15 milligrams. So it's significant, and that can make a lot of people uncomfortable knowing that that's your starting point for a naive person just to overcome the marijuana. And it's, from what I read, 30 days. So that is what I'm recommending to my patients is please try to not use this for 30 days so that my pain medication has a chance of working again. But a lot of times when you meet people, especially me as an anesthesiologist, I don't have that kind of time. So then I tell them that, well, if you have this surgery, but you have 3 more parts to that surgery, so please stop. That way when you come back, it won't be as bad as this time. So given the cardiovascular and pulmonary sequelae, in addition to the cognitive impact, and consider discouraging it at least the day of. So I know that's confusing. What do I do? It is up to you. It is up to you. So for me, I would decide, like, can you actually have a conversation with me? Do I think that you are too sedated? If you're too sedated, I'm not gonna have you sign anything unless it's an urgent. Recognizing cannabis withdrawal. So this is, no, I'm good. Cannabis withdrawal can show as anxiety, insomnia, restlessness, irritability, depression, diminished appetite, or pain. Not a big surprise, but the thing is, when you have somebody come into the hospital, it's not going to show until like day 1 or day 2, which can be confounding because they were doing great and now they're not doing great and they're asking for pain medicine, or they're like really irritable, and they're giving you problems, this is why. It's because they likely don't have access, and post-op day, like 2, 3 is when it's starting to show. And we forget that this can happen. So physiologic effects on the body. So in a naive person, it can cause cardiovascular-wise tachycardia and arrhythmias and hypertension. Some cardiac experts will tell you that this isn't true, and then others will. So again, this is the grain of salt here. You may see tachycardia and arrhythmias and hypertension. In chronic users, you may see bradycardia, hypotension, and vasoconstriction. And cardiac arrest, that is something that has been seen more often. You have almost a 5 times increase risk in your first hour of having an MI when you use cannabis, if you use it chronically. Neurovascular, cerebrovascular, naive will have vasodilation and increased cerebral blood flow, and chronic will have the opposite, spasm and stroke. Respiratory, you might see in the very beginning phase that like it's bronchial hyperactivity and uvular edema, and then chronically it's going to be more similar to those who smoke tobacco, and it's even worse if they actually smoke tobacco and use cannabis products. And then other effects just to be aware of, it can alter your central thermoregulation, increase your clotting time and decrease your platelets, delay your gastric emptying, and worsen your pain. And I can very much at least speak to the pain one. But all of this, again, is not something I would have initially thought about could be related to cannabis, which is why I wanted to at least present it to you today, that if something's happening and you don't know why, it potentially could be related to this. The drug also interacts with anticoagulants, such as warfarin and direct onset anticoagulants and clopidogrel. By just making it all, it increases the levels, makes your INR super therapeutic, and you'll bleed. So post-op considerations, there is evidence of increased pain and opioid requirements post-op in those who use it. We know this. Opioids can be used for perioperative pain in patients who use cannabis. So yes, you can order narcotics, but just monitor them more closely if you can. Or if they are outpatient, just order a lower dose. I mean, it's hard because the lower doses aren't going to work, but you also don't want them to go home and use a lot of cannabis and go into that sedation. So it's a fine line. Personally, I would just really push the multimodal here, but I wouldn't hold back narcotics. So in summary, we're gonna see this become a major problem. I'm thinking by next year, I'll have a whole new set of data for you. But we know at least a couple things for sure. Your risk of MI is gonna go up in that first hour, and you're gonna have a hard time with pain, but there's no consensus on what to do when you have acutely intoxicated person. Thank you so much.